Chapter 23, Endocrine System Drugs. Endocrine refers to an internal secretion or a hormone that is produced by a ductless gland that gets secreted directly into the bloodstream. Hormones are chemical messengers that have specialized functions all throughout the body, and they regulate specific cells and organs. Some hormones you might be familiar with are estrogen, thyroid hormone. They really do have a huge number of different jobs throughout the body. So they're divided up into 4 parts in this book: pituitary hormones, adrenal corticosteroids, thyroid agents, and anti-diabetic agents. So, our pituitary hormones. The pituitary gland is located at the base of the brain. It's the master gland because it regulates the function of other glands. It secretes several hormones and includes somatotropin, adrenocorticotropic hormone, or ACTH, thyroid stimulating hormone, or TSH, and gonadotropic hormones such as FSH, LH, and LTH. Those are discussed elsewhere. The 2 that we'll be covering in this chapter are somatotropin and ACTH. So the anterior pituitary lobe hormone is somatotropin, and it's also referred to as human growth hormone, and it regulates growth. Insufficient production of this hormone will cause growth abnormalities, and those are usually treated with an endocrinologist. ACTH is available only for parenteral use. It's usually used to diagnose pituitary insufficiency, or adrenocortical insufficiency. The drug that I'm referring to is Cortrosyn, and it's strictly used in diagnostic procedures. Treatment is usually corticosteroids to make up for what the body is lacking in. So on to corticosteroids. The adrenal gland is located in the kidneys, and it secretes hormones called corticosteroids, and they act to suppress the body's response to infection or trauma. And so they bring down swelling, they reduce inflammation, and suppress symptoms in acute conditions. So they can be divided into 2 broad categories: replacement therapy when secretions of the adrenal glands or pituitary glands are insufficient, or anti-inflammatory or immunosuppressant agents. Corticosteroid therapy is not curative but supportive. It's kind of making up for what the body's missing. Allergic reactions, that's where they're used for anti-inflammatory effects. Acute flare-ups of rheumatic or collagen disorders, acute flare-ups of severe skin conditions, acute respiratory disorders, and long-term for chronic problems such as COPD, which is chronic obstructive pulmonary disease. Basically, the airways kind of closing up due to irritation, long-term irritation from smoke or whatever the person might have been around for a long time. Corticosteroids are also used for malignancies. Usually in the case of nausea and vomiting, they help the antiemetics be more effective. Cerebral edema to bring down swelling of the brain. Organ transplant to prevent rejection of the new organ, because again it's suppressing the body's immune response. Life-threatening shock due to adrenocortical insufficiency, and acute flare-ups of ulcerative colitis. So there's a ton of different uses for these medications, as you can see. Prolonged administration, whenever somebody's on a corticosteroid, we always taper them off of it. We don't just give it to them for a couple weeks and then allow them to abruptly stop that. Once they're on a corticosteroid, their body gets used to it and stops producing its own steroids. So that's why if we took them off of it, all of a sudden they'd be insufficient, and they could go into what's called a crisis. So usually if we can give it topically and locally, we will. If we can't, we put them on a PO medication, an oral medication, or IV medication, and we taper them down when it's time. There's a lot of serious side effects that go along with corticosteroids. Some of them you may already be familiar with, because I think a few of them we talked to. Delayed wound healing, increased susceptibility to infection, muscle pain or weakness, osteoporosis with fractures, especially in older women. It can stunt the growth of children. It can cause Cushing's syndrome if they're getting too much of a steroid, which is basically hyperglycemia, fat deposits over the body, acne, hair growth, which is growing where it's not supposed to be. Corticosteroids can also cause irritation of the lining of the stomach, so we have to be careful when we're giving them PO, as well as easy bruising and tearing of the skin. It makes the skin a lot thinner. So precautions and contraindications. Again, the first thing is long-term use. We try to avoid it as much as possible, and we also avoid discontinuing abruptly. We always want to taper these medications down. If the patient has a current infection, we want to be careful there as well. We want to be careful in patients with hypertension, hypothyroidism, or heart failure, as well as patients with psychosis or emotional instability, diabetes, glaucoma, cataracts. The list is pretty long because as many things as these drugs help, they also cause a lot of problems. I'll let you guys go through the list of interactions, and hopefully that'll help you get an idea of, I mean, there's a lot of different ones there. We just run into a lot of interactions with these medications. So next is thyroid disorders. Most of you are probably pretty familiar with hypothyroidism, which is a condition in which the thyroid is not producing enough T3 or T4. These hormones are involved in metabolism, regulation of metabolism. So when somebody has hypothyroidism, they might feel slow, sluggish, tired. They'd have an insensitivity to cold, etc. So toxic effects and overdose of the medications for thyroids are going to be exactly the opposite. It's going to be tachycardia, intolerance to heat, nervousness, tremor. So these are two diseases or situations in which the effects are exactly the opposite. So thyroid medications, when we're treating hypothyroidism, we want to be careful in the elderly, in patients with cardiovascular disease, and patients with diabetes. We kind of have to keep a close eye on their blood sugar. We generally give thyroid medications for hypothyroidism first thing in the morning without food, on an empty stomach. And it can also interact with warfarin, so we want to be careful if somebody's been stabilized on warfarin therapy and we're starting them on levothyroxine, which is the hypothyroid medication. There's other different interactions there that I'll let you guys go through, and hopefully that gives you a little overview of hypothyroidism. The opposite, hyperthyroidism, actually looks just like toxic effects of too much levothyroxine or too much thyroid hormone. Hyperthyroidism can be caused by Graves' disease, which is an autoimmune disorder, or inflammation of the thyroid gland, and it's oversecretion of the thyroid hormones. Generally that's treated with propylthiouracil or methimazole, and that's usually short term because the next step would be to what they call radioactively ablate the thyroid, which is where they kind of kill off those cells to bring down the production of thyroid hormone. Side effects of antithyroid agents such as propylthiouracil or methimazole, abnormal taste, blood dyscrasias, and rashes, skin rashes. We want to be careful in anybody, again, prolonged therapy, anybody older than 40, pregnant or lactating women, and especially with propylthiouracil, hepatic disorders. So last but not least, we're going to move on to anti-diabetic agents. You guys are probably familiar with a lot of these agents. Usually, we all know somebody who has diabetes. Most likely it's type 2, which is the adult onset diabetes where there's a decrease in insulin sensitivity. Your body still makes insulin, but your cells are no longer as sensitive to it. Type 1 is usually childhood onset, and those are the people whose beta cells in their pancreas are no longer producing insulin. So insulin is usually used for type 1 diabetics. We do see it used a lot in type 2 diabetics because it really does help control their blood sugar. Usually we'll see it in type 2 if oral meds aren't helping them as much as we'd like to. So insulin is also indicated for stage 2 diabetes. It's always administered parenterally because it's destroyed in the GI tract, so it's either sub-Q or IV every single time. There's different types of insulin. I'm going to have you guys go over that. There's a wide variety out on the market. There's regular or rapid acting, there's intermediate acting, and there's long acting. So the chart on page 457 will help you guys take a look at what the different options are there, as well as the combination mixtures. Insulin can cause hypoglycemia very quickly, so we are very careful when we administer it to a patient. We don't want to cause them to go too low. And hypoglycemia, as we've talked about before, signs of hypoglycemia include tremor, weakness, increased sweating, confusion, tachycardia, loss of consciousness. Whereas the opposite of that, hyperglycemia, causes dehydration and excessive thirst, frequent urination, fruity smell to the breath, and coma if untreated. So let's move on to our oral and injectable non-insulin anti-diabetic agents. These are always used for type 2 diabetics. You will never see these used in type 1 because they just won't help. The first option is sulfonylureas, and the best example, the most common ones you'll see are glipizide and glyburide. Side effects of these medications include GI distress, hypoglycemia, especially in the elderly, and weight gain and water retention. We want to be careful in anyone who has impaired liver or kidney function, unstable diabetes, because again it can drop them too low, and any elderly patient that we're treating. I'm going to skip over interactions and precautions because I want you guys to go over those. Alpha glucosidase inhibitors, acarbose, they delay the digestion of complex carbohydrates, so they kind of slow down the amount of glucose that's getting released into the system. They can be used alone or as part of a combination therapy regimen. Side effects include a lot of GI side effects, loose stools, gas, abdominal distension, and that's all from sort of slowing down that absorption of food because then you've got a lot of food left over. We want to be careful in anybody with liver or kidney dysfunction, as well as anybody who has bowel problems. Biguanides, this is the most common medication that you'll see used in type 2 diabetes. Metformin is the medication that we're talking about. It enhances insulin uptake in muscle tissue and decreases hepatic glucose production. Side effects are usually pretty mild: diarrhea, nausea, vomiting, etc. A lot of GI side effects. There is a rare but serious condition that can happen with metformin, which is lactic acidosis. It's a buildup of lactic acid within the body. In addition, hypoglycemia is pretty rare with these medications, but when used in combination with others, it can happen. We want to be careful in anybody with impaired liver or kidney function. There is a cutoff for creatinine. If the patient's creatinine is above 1.5, I think in female or males, and 1.4 in females, we tend not to use these medications. And next are incretin therapies. These are newer over the past 10-15 years. Sitagliptin, saxagliptin, and are a couple of the, incretin therapies. Yep, those are the oral medications. Byetta is the injectable medication that's available in this category. And what they do is they are hormone mimickers. They mimic GIP and GLP-1, and they decrease, so Byetta, we'll start with that one. Decreases glucagon secretion, delays gastric emptying time, and decreases food intake. Usually results in a little bit of weight loss, which is a good thing for our patients who are diabetic because usually they're overweight. Common side effects include nausea, vomiting, diarrhea, hypoglycemia when given in combination with other medications, etc. Like I said, the oral medications you might have heard of are sitagliptin and saxagliptin. Common side effects are pretty much the same: abdominal pain, GI related. These agents are usually used in caution with patients with a history of pancreatitis. Meglitinides are your nitaglonide and your repaglinide. They stimulate the beta cells of the pancreas to produce insulin. They can be used alone or in combination, and they have a pretty rapid onset and a short duration of action, so they're taken 3 times a day before meals. Side effects include GI effects, hypoglycemia, and weight gain in the beginning of therapy, as well as upper respiratory infections. So last but not least, thiazolidinediones. It's a long word. Pioglitazone and rosiglitazone are the medications there, and they decrease insulin resistance and improve insulin sensitivity in the muscle, liver, and adipose tissue. They come with a lot of black box warnings because they have the potential to exacerbate heart failure. So we do want to be careful in patients with those conditions, heart failure, or any sort of cardiac problem. So that covers this chapter, and let me know if you guys have any questions. Again, everything is due by Saturday, which I believe is the 10th, at 11 p.m. Have a great week, guys.